Good evening, and welcome to today's presentation, CAPG's Guide to Alternative Payment Models. My name is Valencia Harper, and I will be your facilitator today. At this time, all attendee lines are muted for this session to minimize background noise and distractions. We encourage your questions and input throughout this presentation. Please feel free to use the raise hand icon in your taskbar or submit questions and comments in the chat box provided. Today's presentation will include polling questions. We encourage everyone to participate as we value your interaction. Today's presentation will also be recorded and later uploaded to our HealthVisions Delmarva PTN YouTube channel. You may find the link on the flyer included in the invite to today's webinar. We always start our webinars off with a review of our learning objectives. So today we are going to learn ways to provide a primer on currently available alternative payment models and examples of how each works. We have 3 questions to run on. The first, what is the current reimbursement landscape and how did we get here? What models currently exist as alternative payment models? And how can my practice be successful in alternative payment models? Today we are privileged to have with us Mara McDermott, Vice President of Federal Affairs CAPG. Mara McDermott serves as the Vice President of Federal Affairs for CAPG, heading up the association's federal legislative and regulatory activities in Washington, D.C. Mara works on behalf of CAPG member organizations to advance policies that promote coordinated care. This role includes advocacy and education efforts with members of Congress and their staff, the administration, and other health policy stakeholders. Prior to joining CAPG, Mara was counsel in the health industry practice at Aiken Gump, Strauss, Hauer, and Feld. In this role, she focused on a variety of issues affecting health industry clients, with a particular emphasis on health policy and regulatory issues facing physician organizations, hospitals, pharmaceutical companies, and academic medical institutions. Mara received her JD with high honors from George Washington University School of Law and her MPH from George Washington University. She received her BA from the University of California, Davis. I would now like to hand it over to Mara to begin our presentation.
Thank you so much, Valencia. Do I have the ability to move the slides, or do you want me to?
Yeah, you're getting ready to have access here shortly.
Yep. Okay. Great. So are you viewing my screen now?
Yes, we see your screen, Mara.
Okay. Great. Well, thank you so much for having me. It's a pleasure to be here with all of you a little bit late in the day, so we'll try to keep this moving along and keep it interesting as much as possible. Thank you so much for that kind introduction, Valencia. All of that is a long way of saying basically I'm a lawyer and a lobbyist. But trust me, I'm here to help. I know those two things don't have the best reputation in Washington, D.C. all the time. But all joking aside, I'm here to share some of our experiences with you. I will jump into our agenda. I'm going to talk a little bit about CAPG for those not familiar with who and what we are and what we do. I will then turn to talk a little bit about the landscape for alternative payment models. I am based in CAPG's Washington, D.C. office. I interface with Capitol Hill and members of Congress and the administration, and so I'm happy to speak to any of that and share those experiences with you as well. And then we'll talk about CAPG's Guide to Alternative Payment Models. It's a, as the title would imply, a guide to the work that our physician organizations are doing in the APM space, where they're being successful, where they wish those models were a little bit stronger, and we'll have some time to take a closer look at all of those. So to start out with just a little bit of introduction, CAPG, formerly the California Association of Physician Groups, now has roughly 300 risk-bearing physician organizations across 44 states, DC, and Puerto Rico. And we are strong advocates for capitated coordinated care. Capitation is our preferred payment model, and our mission is to proliferate that model across the country. We, as the prior organization's name would imply, have deep roots in managed care in California. So many of our members participate in capitated payment relationships with their payers. About half of our members still in California. The other half of our membership spread across the country, participating in a wide variety of models, which we'll talk a little bit about today. Everything from bundled payments to Medicare ACOs, medical homes, many different types of innovative relationships where physician organizations are taking some amount of risk. So to some degree, they are financially accountable for their patient population. And with that, we'll turn to talking about the APM landscape. So I thought it would be good to start this conversation taking a step back, sort of why are we here? Why are we talking about alternative payment models to begin with? Why is this important? Why does the federal government care? And familiar, I'm sure, to many of you on the line, the delivery system reform movement and this movement to alternative payment models came about in response to a couple of challenges. One of them is that the cost of federal government programs, including Medicare, Medicaid, other federal government spending on healthcare services has continued to increase. And while the rate of growth may have slowed, the percentage of federal spending that is going to healthcare services as opposed to other priorities, roads and bridges, for example, healthcare has continued to consume a greater percentage of those funds, and that causes some heartburn for members of Congress and other federal government officials. The other important thing to keep in mind are the demographic challenges. So we know there's an aging baby boomer population. We know that the Medicare enrollment is increasing at a rapid rate, 10,000 baby boomers every day aging into Medicare. And the system isn't really built to deal with that type of demand. So we're starting to see, for example, or continuing to see, I should say, physician shortages and overworked practices and really a stretching to the max of that delivery system. These baby boomers who are coming into Medicare are also living longer. They have multiple chronic conditions. We just last week had a conference for CAPG where we had a senator from the Senate Finance Committee speaking, and he said, Medicare was put into place at a time when the main challenge that the program was dealing with were, broken hips and broken knees, really crisis care. And now we are moving into a different set of challenges where you have an older population, a bigger, older population that has, needs related to diabetes and other, long-lasting chronic conditions that can escalate quickly if they are unmanaged. And so our federal policymakers, I think wisely, are looking for ways to build a delivery system or encourage the building of a delivery system to meet those challenges. As we think about, I think a little of the strife and struggle associated with the movement to alternative payment models, it's important to keep in mind that Washington, when faced with budgetary pressures, has reacted in a couple different ways. And one of those ways in the past has been frustration, a fancy word for across-the-board cuts. So you'll recall several years ago, Washington looking for money, and they decided to take a 2% across-the-board reduction of Medicare is paid. And in the back of our minds, always lurking is, if the value movement doesn't work, do we return, or does Washington return to this across-the-board cutting? We think of this as sort of a sledgehammer versus a scalpel. We prefer the scalpel, which are value-based reforms that transform the way that care is paid for, transform the way that care is delivered in ways that we think lead to higher quality and lower cost for the federal government in a much more, hopefully, pleasant way than across-the-board reductions to payment. So we've been on this journey for quite a while, and I've highlighted a couple of examples here. I think in recent years, we have, as an organization and perhaps as a broader health policy community, have focused a lot on MACRA, and we are certainly going to talk about that. But just a reminder here that this journey to a quality-based system and a value-based system started over a decade ago. I've put the example of PQRS here, which is the Physician Quality Reporting System, which started as a voluntary demonstration project around 2006. The beginning of collecting and reporting quality information for physicians in Medicare Part B. From there, PQRS started out as a bonus program, transitioned into a penalty program. If you don't report, you receive a reduction to your fee-for-service payments. As the ACA was being put into place, there were additional policies intended to continue to drive the journey towards value-based care in Medicare. So a couple of policies to highlight here: the value-based payment modifier, which was actually fairly similar to the MIPS component of MACRA, where you have an adjustment up or down, a bonus or a penalty on your Medicare Part B payment, depending on how you perform on quality and cost metrics in traditional Medicare. With the introduction of the Affordable Care Act, the passage of the Affordable Care Act, we also saw the creation of accountable care organizations, some legislative text and statutory text around medical home programs, an increased focus on innovation with the development of the Innovation Center at CMS, intended to put forward additional options for physician payment in traditional Medicare and continue the process of reshaping the Medicare system from one where physicians are paid per click, paid for every service that they deliver, to a system where physicians are paid for the value of care that they're delivering. As the ACA and the value modifier and PQRS, and I can never lose sight of meaningful use, of course, every physician's favorite program, rolled out over time, there was a need felt by congressional staff to consolidate those programs, and there was born MACRA, which we'll talk a little bit more about. All of this is to say that we've been on this journey for a long time. We feel like we are making progress. It's slow and it's hard work and it's expensive work, but we're moving forward. So I wanted to just do a little compare and contrast, taking a step back to the good old days, I guess, in January 2015, where we saw in that year, in 2015, some pretty remarkable bipartisan agreements. And the first, I would say, set of the kickoff point for that broad bipartisan moment was when the Obama administration put forward value goals to transform the healthcare system from a fee-for-service system to a value-oriented system. And they put forth what seemed at the time to be pretty ambitious goals of tying increasing percentages of Medicare payments to value over time. So, looking at fee-for-service, if fee-for-service is going to continue, wouldn't be paid just for doing the service, there would be some sort of quality cost component attached to that payment for 85% of what Medicare pays by the end of 2016 and 90% by the end of 2018. They also established goals around moving increasing percentages of clinicians into alternative payment models, 30% by the end of 2016 and half of all clinicians in APMs by the end of 2018. And what was so fascinating about this moment in history was that you had then the enactment of MACRA, the Medicare Access and CHIP Reauthorization Act, which basically cemented that view, those goals around movement to alternative payment models, but came out of a Republican-controlled Congress. So while MACRA enjoyed broad bipartisan support on the Hill, you had this very rare moment of a Democratic administration and a Republican Congress coming together to put forward agreement that Medicare needs to be moving to alternative payment models and away from fee-for-service. And that was pretty incredible, especially I think in the policy environment that we're in now, to have that type of agreement across party lines, pretty remarkable. So I believe that MACRA is familiar to all of you, but I feel like it's always helpful to do a little bit of a refresh. So I've included this slide here with a summary of where we are. MACRA created two separate paths for physician payment in traditional Medicare. One is the merit-based incentive payment system path, where you're paid your fee-for-service normal way of paying fee-for-service, but you would see an adjustment depending on how you fared on measures in MIPS. So 4 categories, multiple measures within each category. We're not going to get into a whole lot of detail on all of that today. But if you are a high performer, you could see a bonus of for the 2017 performance year, 2019 payment year, a bonus or a penalty of bonus as high as 4% or potentially even higher if you are an exceptional performer, or a penalty as much as 4% if you didn't report or didn't meet, in this case, minimum standards around reporting. The incentives and penalties on the MIPS side increase over time. You'll see by the 2022 payment year, a pretty substantial bonus or penalty of 9%. So really, in our view, a strong incentive to get out of fee-for-service, because you would potentially have as much as 9% of your payments, quote unquote, at risk if you did not fare well on those MIPS measures. So if that MIPS path option seems unattractive to you, and I can tell you for many of my members it is quite unattractive, not just because of the financial component, but also because of the burdens of reporting and other rulemakings that you need to follow, you have a second option, that is participating in an advanced alternative payment model. If you participate in a qualifying advanced alternative payment model, you're eligible for a 5% bonus for all of your Part B. There are, I would say, fairly tight requirements around what qualifies as an advanced alternative payment model. Not all alternative payment models are advanced, but if you can get yourself into that bucket of advanced, then you qualify for that 5% bonus. Again, we see MACRA as a federal push towards alternative payment models, and that is something that CAPG has supported and is supportive of because so many of our members are participating or are interested in moving in that direction over time. So moving forward from our bipartisan environment into our current environment, which I would say is the opposite of bipartisan, I wanted to touch a little bit on the Trump administration's record on value. I've seen a fair amount of media attention that I think has been pretty critical of this administration's view on value. We see it a little bit differently. We see the MACRA final rule, which just came out for the 2018 performance year, so next year's calendar year of performance, continuing to push forward on value in a couple of different ways. So they are introducing the cost measure for a weighted cost measure for the first time, for example, continuing to increase a ramp towards value-based payment in that final rule, which we were pleased to see. For those of you on the call saying, yeah, but they canceled the bundles, we know, we saw that, we saw that too, and our reaction was a little bit mixed, I would say. Yes, there's value in the bundles. We are supporters of bundles. We view the bundle payment programs as an important stepping stone forward to higher levels of risk. We have seen with our members the value that bundle payments can bring, especially for clinicians, specialists for whom there may not be other models available. However, there was a lot of criticism of the mandatory bundles. I will say the mandatory bundles are not completely gone. There is a limited in scope mandatory testing that will continue to move forward in one of those handful of demonstrations. And CMS has reiterated its commitment to continuing to have voluntary bundles and rolling out new voluntary bundled payment models for 2018 performance year. So not all hope is lost there. And then the CMS Innovation Center just at the end of September put out a request for information for stakeholders to submit their ideas for new payment models. And in the announcement of that request for information, the CMS Administrator, Seema Verma, reiterated her commitment to the movement to alternative payment models. So while it may not look like what we were used to in the Obama administration, where there was a new rule, new model coming out roughly every 6 weeks, we are anticipating that that activity is going to pick up again, and there will be some new opportunities in the federal space to experiment with alternative payment models going forward. One massive footnote to everything I just said is that there was a HHS Secretary, Dr. Tom Price, who was overseeing all of this until a few weeks ago, or maybe it's been more than a few weeks at this point. He resigned in a fairly high-profile resignation over his use of private jets, which you may have seen covered in the media. And we are awaiting the appointment of a new HHS Secretary there is, Donald Trump has nominated Alex Azar, who is a former pharmaceutical company executive. It is, in my view, yet to be seen how he will approach the value movement. Will he, strike the Obama administration goals, put in place new goals? What's his approach going to look like? And I just don't think we know. And all of that is assuming that he is confirmed by the Senate. So massive footnote there, something to keep in the back of your mind. But from where we sit, we see value continuing to move forward. And the last thing I'll say is that I haven't forgotten about the biggest elephant in the room, which is, of course, repeal and replace of the Affordable Care Act. And one of the questions I get from my members all the time is, if the ACA is repealed, what happens to all the other stuff, ACOs and bundles and medical homes, all the other things included in the ACA? And to me, it's very much, we got a cyclone swirling around us, and we've got our heads down doing our work, and we're going to hope that that cyclone spins off into the distance, far away from us, so that we can continue the important work of achieving value-based care. And all, sort of kidding about this slide, with the slide aside, we absolutely believe the coverage piece is critical, and of course want to have as much coverage as possible for our populations. And the proposals to repeal the ACA that leave large swaths of the population uncovered have been untenable to our members. But we think, sort of regardless what happens there, and hopefully, that means coverage stays in place, there are underlying problems with the delivery system that must be addressed no matter what. And you're not really going to be able to solve the cost or quality problem until you address that underlying delivery system and design and put in place a system equipped to deal with the challenges that lie ahead. So that's my spiel on the landscape. And now we will turn to talking about the Guide to Alternative Payment Models. Valencia,
Mara?
do you want to do the question now?
Sure, we can launch the poll question. And as for 2018, I plan to participate in the following MACRA category. Please select 1, MIPS, MIPS APM, Advanced APM, and what's MACRA? I have about 40% that have voted, and 50% vote for MIPS, 33% MIPS APM, and 17% what's MACRA.
Okay, good. That's helpful. Well, we can do a whole nother webinar on what's MACRA. I'll be happy to come back and do that. And we have some content on our website that can help with that problem, absolutely. So we'll fix that. All right, so turning now to the Guide to Alternative Payment Models. As I mentioned, CAPG members have been engaged in quote-unquote alternative payment models for years, in some cases 30 years. My physicians always sort of give me a hard time about calling them alternative payment models because to them this is just how they're paid. But like I said, we have people on a spectrum, and some of them have been doing this for a long time and some of them are brand new to the space. We started the APM guide, CAPG's Guide to Alternative Payment Models, to highlight our members' experience with both old models and new models. And our goal was to not create a rosy picture that everything in the APM space is going great, but to really share with the audience the good, the bad, and the ugly in delivery system reform and what's going on. I will share with you our bias in terms of delivery system reform and where we're going. Our members have seen great success with percent of premium capitation. So when I say that, I mean in some cases, our members are paid by a health plan a percent of what CMS pays the plan, so or Medicaid. So in the Medicare Advantage example, which is perhaps the most clear, our physician organizations are capitated in amount equal to a percentage of what CMS has paid to the health plan. Our physician organizations then turn to their downstream network, individual doctors, and pay them in a variety of ways. Fee-for-service, subcapitation, salaries, it kind of runs the gambit. But that is where we see the best work being done, and that's kind of where we're pushing all the policy, and as much as we can, we're pushing in that direction. That being said, we know that we have people along this stair step everywhere, and we want to showcase those models as well. So what's in the guide that we're about to talk about, and we'll dive into each of these a little bit more. We have 6 case studies on our experiences. They range from bundles to capitation. This guide is available in your resource, in your handout section. It's also available for download on our website if you want to download it or look at a specific case study in more detail. You have plenty of options to do just that. And we will start by talking about the Commercial Bundled Payments Program. So we identified one of our members, Providence Health and Services, and they are engaged in a commercial bundle and with their Medicare Advantage and commercial populations. The way that it works is that the physician organization and the payer agree on a bundled price for a specific defined episode of care. Then if the clinicians are successful in beating that bundled price and achieving certain standards on quality and efficiency, they are eligible to share in savings. What we have done for each of these case studies is talked about how both the physician organization or system is paid and how individual physicians are paid. So in this case, the plan makes the shared savings payment to the hospital. The physicians receive shared savings payments and their regular fee-for-service payments. So they are continued to be paid fee-for-service, but they are eligible to receive incentive payments, a share of what they are able to save. And in terms of why it works, the physicians in this model believe that it has allowed them to focus on a set of quality and efficiency measures to improve their patient outcomes. They saw this as an opportunity, the physician leadership of this organization saw it as an opportunity to bring their doctors to the table to better engage them on specific quality metrics, on their referral patterns and other things, and enable them to have some higher outcomes and patient satisfaction. In terms of how it's worked, it's provided a better value for their patients in terms of their patient satisfaction scores, patients who were able to improve their functional abilities coming out of their surgeries, and having more patients discharged to their homes, which increased patient satisfaction as well. In terms of suggestions for improvement, one of the major limitations that this group highlighted in their experience with bundled payments was the sustainability over time. And we hear this all the time when we're talking about shared savings models. So when you're sharing in savings, it's relying on you to basically best yourself all the time, right? To continue to squeeze waste out of the system to achieve that savings and then share it. And that poses challenges over the long term. There's sort of less to squeeze out the longer that you're in these models. And so one of the things that this group is exploring is how they could move to a prepaid capitated model in the future. So prepayment for the bundle rather than a fee-for-service payment coupled with shared savings. One other limitation that was mentioned here that feeds into the ability to move to a prepaid model is the availability of data. And this is something that comes up. You'll hear this again as I walk through our case studies. Our physicians are struggling to get the data that they need at the level that they need and at the time that they need it. So some challenges there that I think are common across different types of APMs. How do you get the data from payers, including CMS, when you need it, and how do you make sure that it's the data that you need? And that's a shared struggle that we don't have any easy answers to at the moment. So turning to our next case study, which is the Next Generation ACO. So a little bit of background on what Next Generation ACO is. Next Gen is one of the programs through the CMS Innovation Center. It has been an evolution of what was first the Pioneer ACO program I think from the Pioneer program, CMS learned some things about models and how they work, and then wanted to continue to evolve their ACO offerings, Next Generation ACO, the next in the stepping stones of ACOs for CMS. I think of it as a more advanced version of the Medicare Shared Savings Program. It offers some additional benefits and has upside and downside risk. In the Medicare ACO program, Medicare pays shared savings to the ACO if the ACO is able to beat its benchmark, so they're able to come in with a cost or spend less than what it was projected by Medicare they would spend. They can share in that savings to the federal government. If the ACO overspends, spends more than what CMS predicted it should, the ACO has to repay money to CMS. So they pay a share of those losses to the federal government, a share of what they've overspent. In the ACO models, physicians continue to be paid fee for service. ACOs are our ACO participants are designing their own incentives for their contracted physicians. So individual physicians in the ACO continue to be paid fee for service in most cases, and then they can receive, the individual doctors can receive a share of savings. These incentive payments tend to be linked to quality performance. The ACO has a defined set of quality metrics, roughly 33, I believe, and depending on performance against those metrics, they receive their share of the savings. In this particular case, excuse me, the ACO has limited the number of measures that individual physicians are accountable for to 3 to 5. So they're not saying to their individual doctors, you're responsible for the 32, your payment is determined by the 32. They're tailoring that measure set to those individual doctors, and depending on how they perform on those tailored measures, they can receive a bonus payment in addition to their fee-for-service payment. What is working about the ACO program in this vignette, in the APM guide, and in what we hear about the ACO program more generally, is that it is igniting conversations about aligning physicians and communities towards a set of quality goals, and that the ACO program has really served a role of bringing clinicians together aligned to a specific population, specific goal. This ACO Triad Healthcare Network is the one that is featured in the APM guide. They're located in North Carolina. Found that the Next Generation ACO had a more favorable benchmarking methodology than what they had in the Medicare Shared Savings Program, that there are some favorable, flexible provisions in the Next Generation ACO program that allow you to tailor how much risk you're willing to take and how much upside, how much downside, and that was one of the key features about the ACO program that this particular participant enjoyed. The other benefit of participating in the Next Generation ACO program is that there are waivers that are not available in traditional Medicare. In this particular case, the Next Gen participant highlighted the availability of voluntary patient alignment. So in the Next Generation ACO, beneficiaries can elect to participate if they select a specific doctor. One of the big problems that our members have had with other Medicare ACO offerings is that patients tend to be a little bit blind to the ACO operation, or the fact that their physician is part of an ACO. So a little bit more of a window into the population here, and our participant enjoyed that. Where there's room for improvement, I could probably fill an hour with my members' ideas about how to improve Medicare ACOs, but for purposes of this case study, transparency has been a huge issue. And one of the great things about working with the CMS Innovation Center is that the Innovation Center has flexibility, and they can move problems out of the way. They can address barriers pretty quickly. But what our participants have found in the Next Generation ACO program is that in some cases, CMS is making policy changes mid-year that are unfavorable. and they don't have, the participants don't have a lot of sight into what's going to happen until it happens, and then they're left sort of trying to figure out what it means for their organization, which can at times be very complicated. There was a recent example where CMS had specific rules around stop loss and then offered the ACO population an opportunity, the ACO participants an opportunity to pick a different approach to stop loss, but they offered it in November of the performance year 2017, which obviously creates a ripple effect for the whole year that has already occurred, the 11 months of the year that has already occurred. So some challenges there with transparency with CMS in terms of moving targets, knowing what they're going to be held accountable for in advance. And then the other big issue, which I already alluded to in this program, is patient engagement. So we have long struggled with the notion that patients are passively attributed in most cases to their ACO, and it's based on where they get most of their primary care services or the plurality of their primary care services. But what that can mean for the patients is that they're seeing a primary care doctor in the ACO, but they're also receiving other services outside of the ACO, and they may or may not know the consequences of that or the implications for the ACO. And one of the things that our members have been pushing for is to have a much more engaged patient population. So maybe going as far as to have patients enroll in the ACO the way that they do with Medicare Advantage, maybe having financial incentives for patients to receive care within the ACO network as opposed to outside of the ACO network, or some combination of those things. And that is one of the major areas of improvement for the ACO program. Turning next, our next case study comes from one of our California members, HealthVisions Medical Group in Northern California. And the model that they highlighted, we have dubbed managed fee-for-service. I don't know that that's sort of like the best name for it, but I'll explain how it works. In this case, the physician organization receives a capitated payment from the MA plan, and then the group pays its physicians fee-for-service. So capitated payment at the group level, fee-for-service payment at the individual physician level for both primary care physicians and specialists. The primary care physicians receive a quarterly bonus based on their performance on quality, accurate documentation, their utilization metrics, and patient experience scores. That bonus makes up about a third of the total compensation for primary care physicians. The specialists are paid a bonus, also linked to performance, and it makes up about 5 to 10% of their total compensation. The specialist bonus is based on quality metrics, accurate documentation, and patient experience measures. The reason why this model works is the frequency of the incentive payments. So if you think about a quarterly bonus and then compare that to what I described in the MACRA framework for MIPS. So in MIPS, recall you're performing in 2017 and you're seeing a payment adjustment, bonus or penalty in 2019. Very far divorced from when the actual care is offered, right? 2-year lag. In this model, the physicians are seeing a bonus pretty immediately on a quarterly basis if they're a primary care doctor, on an annual basis if they're a specialist, and our group feels that really allows them to drive performance and provide feedback closer to when the care is performed so that the physicians can adjust if need be. It allows the physician organization to course correct if a measure is not working, or if everybody's having problems with something, they can fix it pretty quickly and be responsive to the needs of those physicians, and that is a strength of this model. Another one is physician engagement. So they engage the physicians in developing these internal performance measurement systems. They make sure the physicians are getting timely feedback, that it's things the physicians feel that they can control. And that has been a big factor in getting buy-in from the physician community and having physicians be engaged and invested in the system. I will say also that, we view this type of system as being totally different from what we would call unmanaged fee for service, where you're just being paid, provide the service, get your payment, pay per click. There is an intense amount of oversight in terms of the quality and efficiency of the care being delivered and the patient experience. And we think that makes it a far preferable model to just straight fee for service. And the way that the physician organizations are able to control that is because they have that prepaid capitation at the organization level that allows them some control over what happens downstream. In terms of room for improvement for this model, a couple of things which I think will come up in a subsequent case study as well. One being the stability of federal government program payments. So when you are paid a % of what CMS is paying, any changes to what CMS pays directly affect the medical group. And to put a finer point on it, a few years ago when the health insurance plan tax was passed as part of the Affordable Care Act, there was a percentage reduction to plan payments, basically intended to offset the cost of expanded population coverage. And many of our physician organizations received a letter saying, okay, well, me health plan, my payments were cut by 2%, and now you physician group, your payments are cut by 2%. So it's pretty much a direct pass-through. So our physician organization participant in this case study is saying, if there's stability in federal government program payments, our payments are stable too, and that's what we would like to see. The second area of critique for this model is when you're dealing with multiple plans. So in some of our crowded California markets, our physician organizations contract with 8 health plans. The plans may all have different quality measures that the physician group is accountable for, or the specifications, diverge slightly in ways that require a lot of effort for our physician groups to bring those requirements together to report to each of those contracting partners. We have been working with the plans to try to streamline that, to bring those quality measures into alignment across different payers, and to take it a step further to align those with what's going on in traditional Medicare as well. So Valencia, I'm halfway through the case studies. Do you want to do the second polling question?
Sure. Thank you, Mara. We can go ahead and launch the last one. It asks, when it comes to value-based payments, my message to Washington, D.C. leaders would be, and please select one, put the foot back on the accelerator, time to move to value, coast in neutral for a while and see what works, slam the brakes, too much, too fast. So we have about 30% that have voted thus far.
Wait till it gets to about 75 at least.
Okay, sounds good. We're at 60 right now, with 33% in
vote.
category. Looks like we're pretty much stuck at 60% that have voted, with 33% in each category.
Thanks, Valencia.
Perfect. All right, thank you. Okay, so next we have a global risk contract with a Medicaid managed care arrangement, and this one was contributed by Pediatric Associates, so a pediatric group in Florida. How it works, the Medicaid plan makes a capitated payment to the medical group. The medical group pays its individual doctors on a productivity and performance incentive program basis. In terms of why it works, this group has been able to use a robust in-house team to perform its data analytics and provide a lot of support and wraparound services for its physicians. So the physicians feel like they have a lot of support coming from the data to help them manage their patient population, to give the physicians the information that they need to allow them to offer higher quality for their patients. This model uses its prepaid capitation funding at the group level to hire dedicated scribes, laboratory professionals, medical assistants, and other team members who, again, wrap around those primary care providers and allow the physician to focus on physician work and the others to focus on their work, with each member of that care team practicing to the top of their license. The model is focused on primary care and preventive care. So they're using their capitated payments to create wellness programs, to manage chronic conditions. The example in the case study is asthma, but they've deployed asthma educators and used the data to kind of cut those asthma hospital admissions down and try to intervene as early as possible to keep their patients out of the hospital. In terms of room for improvement, again, a common complaint is the timeliness and standardization of information from their payers. So they need better data coming from the plan, coming from the Medicaid program to be able to manage that patient population, despite their strong internal data analytics capabilities. What comes in helps improve what comes out, so they need good information coming in a timely fashion. And again, to streamline information and reporting requirements across payers. Okay. The next model, and I think a pretty unique one, comes from an independent practice association in Santa Clara County called SCIPA, the Santa Clara County Independent Practice Association. So they receive capitated payments from health plans and Medicare Advantage at the IPA level. So their independent practice association gets capitated payments. They then turn around and make capitated payments to individual physicians. So those individual doctors are also what we call subcapitated, and they can receive performance-based incentives based on a couple of different factors. One related to how many of their patient panel have had their primary care visit, and then one related to accurate documentation, and then a bonus related to quality. So they're using their capitated payment combined with pretty robust performance incentives around making sure there's no stinting on care and that the care is of sufficient quality to incentivize their physicians and make their model work. Why it works, so their clinicians have been very happy with this model because it creates stability. They know what they're going to be paid. It is predictable. Before they put this model in place, there were different types of contracts with different types of clinicians, and the reimbursement rates were all over the place, but mostly headed downward. The subcapitated model allowed this group to create stable, predictable payment arrangements, and that helps, especially with the independent practice model where you have physicians who are in independent practice who now have a reliable, predictable stream of income. The model also aligns incentives to improve patient care. So this model has allowed the physician, the IPA, to align the incentives for individual physicians to the requirements for their Medicare Advantage contracts and their commercial contracts, make sure everybody's rowing the boat in the same direction. Again, here with room for improvement, this member highlighted overall funding pressures. We've talked a fair amount about that. Where these groups are capitated downstream from their payers, any disruption at that higher level creates disruption for the physician organization as well. And then where they've created, I think, challenges for themselves or challenges that they've faced is that the physicians have to feel that the bonus criteria are reachable. So if they set goals for those performance-based incentives or those performance-based bonuses that are out of reach, they will lose the physician's attention and the physicians will ignore them. They have to set metrics that foster improvement but don't scare people away, and that's an ongoing challenge that they face as they continue to refine their payment model. Then the final case study here is a commercial pay for performance program. I'm not going to spend a lot of time on this one because it's pretty specific to California. In California, there's a statewide commercial P4P or pay for performance program. It's run by an organization called the Integrated Healthcare Association. It's a really, really neat program, especially given the size of the state of California. The payers and the physician organizations came together and decided to align around a specific set of quality measures. The health plans put in money to fund bonus payments that would go to the physician organizations to invest in infrastructure and other things. So physician compensation in this model varies, but the pay that they receive is tied to their performance on a specific set of quality measures. In many ways, it's a MIPS microcosm. They've created in the state of California performance-based incentives on quality and cost, and they're doing it statewide in a pretty, I would say, innovative way. And there's a lot more information about that on the IHA website for those that are interested in learning more. A fascinating program, but if you're not in the state of California, its relevance or applicability to you maybe or is pretty limited, unless your state is going to take that on, and maybe that is in the future. So that one I'm just going to sort of leave for now, unless there are questions about it at the end. So in terms of key takeaways, I see we're getting close to the end of our time. I would say that the movement from volume to value continues, although it is a bit slower than it was in the Obama administration. So continuing to move forward, continuing experimentation. We still think value is where we're going, and for long-term financial success, value-based contracting is where our members want to be. There are many models to choose from all along the spectrum of risk-based coordinated care, whether that's a bundle or a percent of premium contract. Lots of options that are available. The attractiveness of them and your ability to succeed in them depends on a wide variety of factors, including your physician readiness, your market, your benchmarks, and myriad other things that impact your ability to succeed in an APM. No matter where you are on that spectrum, we hope you'll view CAPG as a resource going forward. We have a ton of free educational content available on our website. We often do webinars. We send out notices. We've got a pretty active education department with different offerings, and we hope that you will check those out. Again, you can view the case studies in the handout portion of this webinar. You can also download those case studies from our website. They are free. You just need to give us your email address, and we'll give you all the case studies. You can download them one by one, or the entire book, depending on what you want. I should mention there's also a 2016 version of the case studies that has 14 additional models, so no matter what you're looking for, you can probably find it on our website, and we would encourage you to take a look. You can join CAPG as an individual member at imcapg.org. It's just $10 per year, so it's a bargain. And you'll get updates from DC. If you are interested in that type of thing, I would encourage you to check that out, and that's all available on the website. Stay up to date with us, and I hope that you have all found this valuable. I'm happy to take questions now, or you're free to email me if you want to take your question offline. I'd be happy to speak with any of you at any time.
Thank you, Mara. We do have one question. It states, normally, do medical groups have much opportunity to provide input into which quality measures will be used to judge performance?
So my sense of that is no, they don't. I think, you know, our groups are trying. We've come together with a plan to identify measures that we think are most appropriate. Certainly in the Medicare space, you have no say, right? I mean, the rule comes out, those are the measures, and you can provide input to the rule, of course, but we're not seeing a lot of movement. We're hopeful to try to consolidate some of those measures. I know some of my groups are reporting on over 100 measures, so we're trying to consolidate.
Okay, great.
Mara, this is Cindy. I have a question, kind of an observation and a question. It seems to me that because of the quality measures, because of how performance will be looked at, it's going to really be important from a data perspective for practices to have a good mastery of their EHR or registries or whatever it is that they're using to capture and then analyze data. First of all, would you confirm that? And then secondly, do you see successful practices being able to use their basic EHR to do that kind of data capture and analysis, or are they needing to use other tools also?
So I totally agree with that observation. In terms of what our groups are doing, it depends. I mean, some are using the EHR, some are, you know, hiring consultants to help. I think it just depends so much on where you are and what your what you're trying to do. But I think it's a huge challenge, and I think a barrier for a lot of our groups in terms of how successful they're able to be in especially some of the more advanced APMs.
Thanks.
Okay.
Valencia, I was going to say, I see another question. Under the questions.
Okay.
Do you want me?
It says a lot of practices, when asked, do you feel ready for an OCO, they are fearful to say yes because they often associate being in an ACO as losing all their individuality and power. What advice or pep talk, so to speak, do you have for practices like that?
So I hear this all the time too. I agree with the questioner. So we've seen independent practice associations succeed in the ACO model. And that has allowed clinicians who participate in those ACOs to maintain some independence. They don't have to be on salary at a hospital or part of a health system. They are able to maintain their independent practice and participate in those ACOs. That model is rare. I don't think I need to tell you that. Those are rare, but they are successful, and I think some of the most successful ACO participants are in that type of model. I'm thinking in particular of our member Monarch in Southern California, which uses that model. It is a challenge, and my pep talk would be that the world is changing, and the requirements the federal government is putting on clinicians is changing. And so to deal with those challenges, it's almost like you need a partner, and who's that partner going to be? And so I think it is a time to, not abandon the notion of independent practice, but figure out who is a good partner for you, who can support you on the things you need to do. Whether that's an ACO or not, it's probably going to have to be some sort of partner. I think it would be very difficult to comply with a full host of MACRA requirements completely on your own. And finding a good partner is hard work, and we've got full sessions devoted to that on our educational series.
Okay. All right, great.
Well, that's good to know, because that's a referral we can make to those practices is, check out the resources available on the CAPG site, because maybe that would help them to feel more comfortable.
Yeah, I think so.
Okay. It doesn't look like we have any other questions or nothing else in the chat box. So we certainly thank you, Mara, for your time with us this evening and giving us the case study examples as well as the historical data, and along with the incentives that are available in performance years moving forward. So we certainly thank you for your time this evening.
Well, thanks for having me, and I really enjoyed it, and I will talk to you all soon.
All right, thanks, Mara. Thank you, everyone. Have a great night and a great Thanksgiving.
You too.
Thank you all.